Okay.
That's what I
So, we talked about last week in chapter 25, we were just going over the Ballard scoring. And that, the other things I wanted to cover on that chapter is skin characteristics that are mostly benign, but there are things that you may see on your newly delivered baby. Two of the important things that you may see on a freshly delivered baby is a cephala hematoma or a caput secundum, okay? These are things that happen to the head from delivery, okay? So the cephala hematoma is basically what it sounds like. It's a big old bruise on the head, okay? Now, the important thing about this, I don't have a picture of what we call a subgaleal hematoma, which is really bad. They're pretty rare, and your baby can hemorrhage in this type of brain bleed because it's in the brain tissue. These are actually above the cranium, between the skull bone and the skin. So the cephala hematoma is a collection of blood. It does not cross the suture lines. Okay, so that is the distinctive difference between a cephala hematoma and a subgaleal hematoma. Okay, is it does not cross the suture lines. So if you remember, the baby has sutures on their head where the bones have not fused. So if it doesn't cross the suture line, this suture along the head here, so that bruise will be right here and it'll stay right here. It won't spread through the head. Okay? And the caput secundum is basically just edema. Okay? That head was just being mashed against some pelvic part, and it did not bruise, but it did cause edema. And that can cross the suture lines. Okay? And they feel and look quite different.
So that brain bleed that you mentioned, that one does or doesn't cross the suture lines?
The subgaleal
Yeah.
one, it does cross the suture lines. Okay? That is not on your exam, by the way, subgaleal. I don't even think the text covered that one.
So you can't see that?
You can see that one.
You can
Yeah.
see
Mm-hmm. I don't know where my smart board things are, but here. So this is the caput. Caput secundum, you'll hear it just be referred to as caput. But you can see, oh, shoot, see now? It's just a collection of fluid. And you can see right here is a suture line, and it does cross over, okay? It feels really kind of spongy, okay? Now this picture is really hard to see, even probably if I turned off the light, because even on the slide I can't really tell. But this baby does have a caput. It's just very hard to see on this baby. Okay, now this is your cephala hematoma. This is a collection of blood under the skin. And here's the suture line, and it does not cross it. And that can feel kind of firm, as opposed to the caput. The caput's really kind of spongy. This can feel a little bit firm, and the skin will look bruised. Okay? Now, both of these will resolve in a couple of days without any intervention. Now, this one you can see really well. Right here is where this baby has the cephala hematoma. Okay? Okay, so now we're going to look at some other characteristics of the baby. One of the things that we assess on our babies are things called reflexes, things that we normally see in the baby. And this is the tonic neck reflex. So if you lay your baby down and you turn your baby's head to the side, whatever side that is, the arm and leg should straighten. The other ones may flex. Okay? That's the tonic neck reflex. This is just showing a palmar grasp. So when you put something in a baby's hand, they will grasp it. A baby with a neurological problem will not. Or a very preterm baby, depending on how preterm they are, will not. And it's the one reason why when parents ask us to put the handprints in their baby book, we don't do that. As soon as you put the ink pad on their hand, they go like this. So. Okay, the Monro reflex is basically just a startle reflex. So, you can do this. This will happen as you're doing your assessment. If you roll baby to one side, or if you lay baby down and just abruptly take your hands away, loud noises, of course, the baby will startle. That's called the Monro reflex. So the more preterm they are, or if they have a neurological condition, you won't elicit this response. Rooting reflex. So we assess this, and this is how we get babies to latch on when they're breastfeeding, is that we will rub the nipple or a finger along the side of the baby's mouth or cheek, and the baby will turn towards that with their mouth open. Okay? That's the rooting reflex. And the stepping reflex is if you hold a baby up, they will act like they're stepping. Okay. And the sucking reflex is you put something in baby's mouth and they start to suck. So we check this when you got your baby laying there and you're doing your initial head-to-toe assessment, and you put your finger in the baby's mouth, gloved finger. One, you're looking for whether they have an intact palate, and then two, you're looking to see if they try to start sucking. Preterm babies will have issue with this, not because they have a neurological problem or something, but preterm babies have not developed the cue to start sucking yet. So that's why we have feeding issues with really preterm babies. Okay, now this is where we get into some really cool looking stuff. So you might want to know these terms. Acrocyanosis is a bluish color to the hands and feet. This is really evident the first hours of birth and can last up to 24 hours. But if a baby is cold, or they'll be shunting all their blood to their important organs to stay warm. But the other thing is, as their body gets used to taking over their own circulatory system outside of the uterine environment, they will shunt blood to their core, and that's why you'll see blue or purple looking hands and feet. Parents can be concerned about this. Oh, my baby's doesn't have enough oxygen because they got blue hands and feet. Just assure them this is normal. There's nothing wrong, and this should alleviate within 12 to 24 hours. Okay, modeling is a lacy pattern of the skin. When you look at the skin, it will look blotchy, lacy looking, okay? And they can develop this because they're cold or they've had an apnea issue of some sort. and we'll see a picture of that. Harlequin sign is the clown sign, okay? One side of their body is pale or pink, normal newborn color. The other side is really red, and you will see a definite line, okay? Like someone took a crayon and colored two different colors on this baby. There's nothing wrong. It's just something that occurs, okay? As babies are, learning to take over their own circulatory system, they're getting the kinks worked out. There's nothing wrong with this baby. Erythema toxicum, which is commonly known as newborn rash. They look like a little white, pimply looking thing with a little red surrounding it. Okay, it could be on their face, their arms, their legs. The one thing you want to educate your patients about is don't try to scrape these off. Don't put medicine on them. Just leave them alone. They'll go away. Milia is the little white looking dots on the nose usually. Okay. And the vernix caseosa or vernix is just the cheesy substance that is on the baby's skin right after delivery. The more preterm the baby is, the more cheesy they are. The more term they are, the more that has been absorbed. Okay, and the function of vernix is to keep the baby's skin lubricated while they're in this water environment. Okay, some birthmarks you might see. Telangiectatic nevi, or stork bites for those who are enunciation challenged. They're just red spots usually on the up here between the eyebrows, on the eyelids. It could be in the back of the nape of the neck. These fade within a couple of days. A Mongolian spot is a bluish or black looking, purplish looking, looks like a bruise. And it's usually on the low back of babies. It could be on their butts, it could be on the back of their thighs, it could actually even extend up the back a little bit. You see these in dark race babies, okay? And they usually fade over time. Nevus flammeus is a port wine stain. It's just a little capillary bed right below the skin. It's not elevated. It just looks like a red, it just looks like red, an area of red skin, okay? It could mean nothing, but it also could indicate Sturges-Weber syndrome, which is a neurological disorder. But don't be saying, oh my gosh, your baby has, okay? It just could be benign. Nevus fasculosus is a strawberry mark. It's actually it's inflamed capillaries or dilated capillaries that have massed together. They make a large bed on the skin. They can be it can be very raised. It's really rough, like a really nasty looking mole, but it's bright red. Okay, these will usually go away after time. Okay, now we'll look at some pictures. Okay, this might be difficult to see, but the baby's hands and feet are a little bluish. Okay. This is modeling. Can you guys see that? Can you see like a lacy pattern on the legs? Maybe that might help. Does that look any better? Okay, that's modeling. Here's your Harlequin sign.
Do you see that very often?
Once in a while. Not, I mean, not, and actually, one of them that I saw in particular was horizontal. But, yeah, once in a while.
And what causes that?
You know, it's just, it's nothing really significant, okay? Nothing, but it's just the baby this is freshly delivered baby, and they're just kind of getting used to their new circulatory system now, and sometimes it can show up like that. There's nothing wrong with the baby. There's no pathological thing going on, okay? Okay, this is the erythema toxicum. This is the newborn rash. You can see this is like a little white pimply looking thing right here, surrounded by a red base. Newborn rash. Don't tell your parents, don't pick at those, okay? They'll go away. And if you can see, this baby's nose has all the little white pores there, the white sebaceous glands. This is milia. Don't let them pick at that either. That will fade over time or resolve over time. This is a picture of a stork bite. So between the eyebrows and then on the baby's lid there, you can see, you can see just little red areas of the skin. And here is your Mongolian spot. Can you all see, like, here looks a little purplish, blackish, and right here on the right above the sacrum there. These are not like bruises, like baby was sitting wrong or the deliver person was grabbing too hard. These are just pigmentation of dark-skinned children. And here's your port wine stain. So just some capillaries here at the surface of the skin, okay? This can be benign, or it could be indicative of that Sturges-Weber syndrome. But you'll just document it in your chart and just let the physician know, and they'll do what they want to do, further testing if they feel a need. Nevus vasculis. So this part of the baby's capillaries.
Strawberry mark?
Yeah. Okay.
Well, which ones are the ones that are bad?
Huh?
The bad one was
The port wine stain is the only one that's really related to any type of disorder, but then again, it may or may not be. Okay. The hemangiomas, I didn't have a picture of. They could be related to disorders as well, or not. So
none of them are really set in stone.
none of the other ones have any pathological association with them at all. Just the port wine stain could possibly be, and the hemangiomas could possibly be. Okay.
Do the hemangiomas go away?
Yeah, it takes a long time. And as a matter of fact, they can grow bigger for a while before they stop growing and then start receding. Okay. Now, any specific questions as far as the quiz is, or the test is concerned? Any topics in which you want a further review on? I I do want to go over fetal heart rates,
Yeah, that would be helpful.
okay? There may be some questions about fetal heart rates on the test.
Are they gonna be really close, or are they gonna be,
What's really close mean?
well,
Okay, so first of all, normal baseline fetal heart rate is what? 110 to 160. You look at an average tracing of 10 minutes to determine that, okay? In that 10 minutes, you want at least areas of 2-minute solid tracings, okay? So most of the time, you don't have difficulty getting a solid tracing. Sometimes you do. If you do have a difficulty getting a solid tracing, go in and adjust your monitor, okay? But anyways, 110 to 160 is a normal fetal heart rate, okay? So if you have a normal fetal heart rate at 120, and then all of a sudden you have let's just say you have a fetal heart rate of 110, okay, after that. So in order to say it's a baseline change, that change in that fetal heart rate must be a minimum of 10 minutes to say you have a baseline change. If it's less than 10 minutes, we're going to call it something else, and we'll go over those things.
Is that continuous?
If your baseline is 90 for longer than 10 minutes, what is your baseline called? Bradycardia. If your baseline changes to 170, what is your baseline? Tachycardia. Okay. Now, after we look at, I may have went too far. After we determine what our baseline is, then we're going to look at the variability of our tracing. Variability tells us, okay, wait a minute, I need to do something. Variability tells us the oxygenation status of our baby, okay? So if we have a normal heart rate, but we don't have good variability, we might have a problem, okay? So it's very important after we determine our baseline to determine our variability. So our variability is the beat-to-beat variations. It's the up and downness of this strip. All these up and down differentiations here, okay? And they can be in a range, a beat-to-beat range. So each line on this strip, the horizontal lines are 10 beats difference. So you can't see this really well, but this darker line is 120. The lighter line is 130, 140, 150, 160, and so forth and so on. So between those lines is 10 beats. So when we try to determine our variability, we're kind of assessing how many beats from one variation to the other, an average over the 10 minutes. Okay? So it would be inappropriate for me to look at this little section and say, oh, that's my variability. Okay? I have to look at the average over the 10 minutes. Okay? And so if you remember, there's 4 different categories of variability. The first one is absent. So there is no beat-to-beat difference. Oh, crappy darn. Um, and as we learned, the few that were in clinicals yesterday, remember, these are just guidelines, okay? Your baby will not present textbook all the time, so you have to use your critical thinking skills and your assessment over this strip to kind of say yay or nay on what something is. But basically, this first strip here is absent variability. Now, we do see some subtle up and downs there, but in general, the average assessment of this variability is absent. So your baby has an oxygen problem. I don't care if their heart rate is normal. I'm going to address this. Okay? That's absent. Minimal is the next category, and you have 5 or less beats variation in the heart rate tracing. So if you were to really be able to look at this, you could see that, yeah, these changes only take up half of that little block, okay? So 5 or less. This is minimal variability, so we could say our baby has an oxygen problem, but sometimes with minimal variability, babies can be sleeping, and they can demonstrate a minimal variability, but there's nothing wrong with this baby. Or we could have just given narcotics to mom, okay? So with minimal variability, I'm going to look at the history of my strip and see, you know, I've had this patient for 4 or 5 hours. This strip has been minimal variability the whole time. So I'm going to say, yes, I do have an oxygen problem. When your baby is in a sleep pattern, it usually only lasts 40 minutes. Okay, and then you'll see. So you might have 30 minutes of minimal variability, but the rest of your 5 hours have been moderate variability. Okay, so I'm going to say my baby's in a sleep pattern. Now, if I had to document, if it was my documenting period of time, I would have to say minimal variability. Okay, but I would not say that without a comment. Okay. Now, this third one is moderate variability. That's 6 to 25 beat variations. And if we were to look at, if we were able to sit down and see this strip really well, you know, we could see that some of these variations are a whole 20 beats. Some of them are only like 10, but that's moderate variability, and that tells us our baby's oxygenated. Now the last one is marked variability. It's greater than 25 beat variations. On marked variability, you have a really difficult time assessing what your baseline rate is. We can see a little bit on this first part of the strip, and then we can see a little bit on this, the latter part of the strip. But marked variability tells us that our baby is telling us, hey, listen, Mike, I feel like I'm running out of oxygen. I'm trying really hard to get oxygen. That's why I'm doing this, but I'm not going to be able to keep this up, so you're going to have to help me. Okay? So we've determined our baseline rate. We've determined our variability. Now we want to ask, does our baby have accelerations? Accelerations are increases in the heart rate, and for the term baby, they have to increase 15 beats above the baseline for 15 seconds. Okay, you'll see some that are 10 seconds, 10 beats above. Those aren't really true accelerations in the definition sense. Maybe those are part of your variability. But anyways, we're looking for accelerations, and this baby up here that has moderate variability, I have several accelerations that meet the 15 beats by 15 seconds. We call that 15 by 15. Okay? So if your baby's having accelerations, they're having a normal, healthy physiological response to a stress. A stress can be the baby's moving and kicking. A stress can be you did a badge exam and you rubbed the baby's head. A stress can be a contraction, okay? So just like we run up a set of stairs or hike to the M, our heart rate is going to increase. That's normal. It's what it's supposed to do, okay? So we determine if we have accelerations, and in our charting we will say they're either present or absent, okay? Now the next thing we need to look at on our strips is, here's some more pictures of accelerations, okay? Oh, I always skip over this one. Prolonged acceleration. So an acceleration that lasts 2 minutes or more, okay? But less than 10 minutes, because if it lasted longer than 10 minutes, what is it? It's the baseline change, okay? So a prolonged acceleration is more than 2 minutes, and that's fine. You can have a baby that's doing jumping jacks in there, okay? I've had prolonged accelerations that, like, I probably should have called a baseline change, but I knew they were accelerations because I'm sitting there and I'm hearing this baby. I can hear it on the monitor. This baby is just really flipping out. And it's hard to determine a baseline because you just know a baby's just going absolutely crazy in there. All right. So, so we've determined our baseline. We've determined our variability. We've determined if we have accels. Now we need to look to see if we have any decels in the heart rate. There's I said this wrong last time, early, variable, late, prolonged. There's 4 different kinds of decelerations, okay? The first one we're going to talk about is early decelerations, okay? Early decelerations mirror the contraction. So they happen at the same time, they end at the same time. And the one important criteria for early decelerations is when it leaves the baseline and drops to the lowest point, its nadir, is 30 seconds or more. It takes more than 30 seconds for it to drop. That's called a gradual drop, okay? And then it returns, okay? Now, I don't know if we got to see this in clinical yesterday, but sometimes the decelerations are only 30 seconds long to begin with. So here's your critical thinking. Yes, it does not meet the criteria, okay, because it only lasts a total of 30 seconds, but it starts at the same time as the contraction, it ends at the same time as the contraction. It's probably an early deceleration, okay? Now, early decelerations tell us that the head is being compressed. So if I put a belt around your head and cinched it up tight, it's a vagal response. Your heart rate would drop just a little bit, okay? It's a normal physiological response to head compression. We see head compression when that baby's head starts passing through the narrowest points of the birth canal, okay? That tells us, oh, cool, labor's almost done. We're not going to do anything about these, except maybe set up our delivery table, okay? There's nothing wrong with baby here, okay? Okay, late decelerations. Late decelerations are bad. Anytime you're late, that's bad. There's a statement early in that they take 30 seconds or more when they leave the baseline to their lowest point, which is the nadir. It's a gradual drop. The difference from the early is that it happens late in relation to the contraction. So the contraction has already started, and usually at the peak of the contraction, that's when the late starts. And then the contraction finishes, and the late is still trying to get back to baseline. Okay? Late decelerations tell us that there is a utero-placental insufficiency. So bottom line, baby is not getting good oxygen exchange. Okay? So you need to help that baby out.
How, just do the position change?
We'll talk about that, but yes, we, whenever you do intrauterine resuscitation, it's position change, IV fluids, oxygen, turn the pit off. Call your doc. Okay, in that order. All right, so those are late decelerations. Now again, the late deceleration may only be a total of 30 seconds. That doesn't mean it's not a late. What we need to look at then is when is this contraction, or when is this deceleration occurring? Is it occurring after the contraction starts? And is it returning after the contraction ends? So critical thinking will say, you know what, this is a late, even though it was only 30 seconds long. Okay? So you're going to treat those. This next deceleration is called a variable deceleration. It's abrupt from the time it leaves the baseline to it gets to its lowest point, which is the nadir. That means it's less than 30 seconds that it drops. Okay? They can look like a V, they can look like a W, they can look like a U. But they definitely look like they're abrupt, whatever shape they take. Okay? Now, like the late and the early decelerations, you know, it may, late or early deceleration may only be 30 seconds, so it doesn't meet that criteria of the gradual drop. The one thing about the variables is it's supposed to be less than 30 seconds, and sometimes it's more. But does it look like a variable? Okay? Or a better question is, does it not look like a late? So then, okay, we're going to call it a variable. Okay? Variable decelerations tell us cord compression. Okay, so the analogy I've always used, and you'll hear me use again, is I take your blood pressure, I pump up the blood pressure cuff, and the pulse in your wrist decreases. That's normal. I release the blood pressure cuff, and your pulse returns to normal. That's normal. This is a normal response to cord compression. We are compressing those vessels in the cord. Okay? However, when we compress those vessels in the cord, we are decreasing blood and oxygen to the baby. So, if this baby continues to have these repetitively for hours, every 2 minutes with a contraction, you're going to get tired. Okay? So, next time you're at the pool, go under the water for 30 to 60 seconds, hold your breath, do it every 2 minutes do it for 2 hours and see how tired you are at the end. Okay? Baby will get tired and start showing us other problems with their heart rate. So when we see these, we won't get all panicked like we do with late decelerations, but we will try to treat these to alleviate them so that we can stretch this baby a little longer. And then the last one is the prolonged deceleration. So prolonged meaning it lasts more than 2 minutes, but less than 10, because if it lasted more than 10, what is it? A baseline change. Prolonged decelerations are bad. They need treated, okay? Because one of these times that prolonged deceleration is going to be a baseline change, and you're going to be racing to the OR. Now, when I talk about you need to do something about these, there's 4 cardinal things you do. First and foremost, no matter what, every single time, reposition mom. And usually the best position to put her on is the left lateral. And one of the theories behind this is that big vena cava is on the left, on the right side of her body, and when you put her, and that big uterus is sitting on there, when you turn her to the left, it takes some pressure off that vena cava. Okay, so we're trying to increase the cardiac output and then improve baby's ability to exchange. Now, so first and foremost, every single time, period, change your mom's position. I'm going to say that again. For some reason, I want you to know, first and foremost, you need to change mom's position. okay? The next thing you'll do, and probably simultaneously, a lot of stuff happens simultaneously, is you will give her a fluid bolus, and if you're there getting her a fluid bolus, shut off the Pitocin if it's running, okay? And then the next thing you do is you put oxygen on her. 10 liters, period. Now, I've always said 10 liters non-rebreather mask, period, but I just learned the other day that they have developed a new mask, and I forget what it's called, and I need to find out. But it's not a simple mask, however, it looks like a simple mask. But it is a special mask that delivers 100% FiO2 to mom. And so anyways, 10 liters, okay? So if the question says 10 liters non-rebreather, that's the answer. If it says 10 liters nasal cannula, that is not the answer. All right, and then shut off your Pitocin. And then you evaluate, of course. Every time we do something, we evaluate, right? So if we get rid of the bad heart rates, do we need to call the doctor? You better. If they come in and see that strip and they weren't called, they weren't notified, they're going to be mad. Yeah, you did fix the problem, but they need to know. Because if 6 hours down the road you call them in stat, they're going to come in, what the hell? You know, what's been going on? Like, why am I just hearing about this now? Okay? Now, if you don't fix these, and for these I'm mostly referring to the late decelerations and the prolonged decelerations, you're definitely going to call your doc and say, you need to get in here. I've done everything I can do. I cannot alleviate these decelerations, and you need to come in here. And they will come in and they will decide whether or not you get to sit and watch those the rest of the day, or whether or not you're going to go to C-section. Now, the one thing about fetal monitoring is it's increased the C-section rate. Now, the problem is we don't have a good way of determining baby's actual oxygenation status. So they did trial a device several years ago. Mom had to be ruptured. This device went into the uterus, into the amniotic sac, so she had to be ruptured. It was placed on baby's temple. It was like a little pad, and it read baby's O2 sat. So if baby's O2 sat remained normal, although baby was doing all these bad heart rates, we would let her deliver vaginally. We would wait and wait and wait. But the studies were bad. We had some really poor outcomes with that, so that device is no longer in use. So, you know, how long are you going to sit there and watch those before you take her to C-section? You know, they have a very small window, okay? And, you know, who knows if they just would have been more patient if baby would have made it to vaginal delivery. Who knows? Or maybe if we would have waited and waited and waited, we would have had a baby with heart rates in the 60s, and we would have been rushing to OR, hoping and praying we got the baby out soon enough. So that's your decision. Like, who wants to go there, you know? So fetal monitoring, so that now that we see everything bad baby's doing, we cut women a lot because we're scared. And we should be, because, well, one, we might lose a baby, and two, we might lose our license because we could be sued. Okay? OB is a very, 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 very high litigation area. And unfortunately, and I've been to court for OB, unfortunately, a lot of cases, even if, when it comes to a baby who has cerebral palsy for the rest of their life, someone wants someone to help this family financially take care of this baby. And whether you did it right or wrong, you know, you might have a sympathetic jury. And if you have a sympathetic jury, there's nothing you can do about it. All right, so what questions do we have about heart rates and what we do about them? Okay, no questions.
So stopping the Pitocin stops the contraction, and putting more IV fluids is to help.
Okay, So when we stop the Pitocin, we don't necessarily stop the contractions,
Okay,
but we
fine.
stop them to be as frequent and as strong, okay? So that alleviates a little bit of pressure on baby. The fluid does kind of two things. The fluid supplies extra blood volume, so we're getting more cardiac output, so we're getting more gas exchange through the placenta. The other thing that a fluid bolus does is it hydrates the uterus so that it relaxes a little bit. So we're double whammying the contraction frequency and strength.
How big of a bolus is it?
Usually it's 500 to 1,000 cc's, whatever you got in your bag actually, and it's as fast as you can get it in.
Okay, so I go in there, I reposition. At the same time I'm repositioning, I'm probably just turning the bag wide open right there.
Mhm.
At that same moment,
You're shutting the pit off.
I'm shutting the pit off.
And then you're
I'm
grabbing-
going for oxygen.
Right. And then you wait,
And watch the
and then you
breath.
watch. You wait and you watch, okay? And then, you know, after 10 minutes or so of waiting and watching, you're still having repetitive lates. Repetitive meaning they're happening with more than 50% of your contractions. Then you call the doc and you say, or you know, you could try to flip her again, okay? There's only so many ways you can put a pregnant woman. You can flip her again. And then you call the doc and you said, I've done everything I can. You need to come in. Now, I've had docs that come right in, and I've had docs who were either on the green or they were right in the middle of their office hours, and they say, tell me what's going on, what have you done, and okay, so I'll be there in an hour or two. No, you come right now. That's what you tell them. You come right now. Okay? The one thing about variable D cells, I'll tell you, is remember that's cord compression, right? So there's more ways to get cord compression than contractions. So if she has decreased amniotic fluid for whatever reason, she could be ruptured, or she could be, her bag of waters could not be ruptured, she could be intact and still having variable D cells. That means she probably has a low amniotic fluid level. We can see cord compression with that.
Can I interrupt for 1 minute?
Yep.
Or do you have a break?
We can take a break.
All right. This will be quick. Thank you, Jesse. Jesse brought this to my attention. You all have heard about graduation and graduation applications. So I just went over and picked up a stack. So these are the graduation applications. There's a process. Nothing's easy. It seems like more hoops. So you will each pick up one of these, and you'll fill out the front and the back. You'll have to be sure, and you fill out this top part, and then let's see, I think, do you sign? And it talks about this information on the back. You bring these to me with a copy of your transcripts from CyberBear, and then I fill out an audit form that I have to sign off on. So I sign this form and I fill out an audit, and then I turn them all over to Tim, and then you have to pick them up from Tim, take them over to Troy. I don't know if you knew Jordan, but he replaced Jordan. And then he goes through his audit, and then he checks it off, and then you just take it over to the cashier and pay your graduation fee. Does that make sense? So that being said, I need these by, if you could have them to me by October 9th, which is a Friday, then I can have that week, the next week, to get all the audits done, and to Tim, and then you have a couple weeks to pick them up and take them over to the registrar, because I think the date is the last Friday in October, which is October 30th.
Do you need previous transcripts as well?
Yes, unofficial, everything unofficial, because I have to mark down where your,
Credit card?
yeah, where they're coming from. We don't care about the grade so much, we just need to know that you took it and you passed, and when and where, because then he has to do a search to find all that. So I'll leave these here, you can pick them up, and I'll Makes sense to everybody? Okay, so the process is, you grab one of these, fill it out, bring it to me with your unofficial transcripts, and then I fill out the audit that week, get them over to Tim, then you pick up your paperwork from Tim and take it over, and that's when you pay and turn them in to the Troy over in the registrars.
Is there another graduation form as well that we need to turn in with the $40?
This should be it.
That's it.
That should be it. So you don't have to go over there and pick this one up. This should be the only one. And then I just need this with your unofficials. So thanks. Like,
You're welcome. Thank you.
I need to follow up on this. All right, thanks, guys. Thank you, Wendy. I'm sorry to interrupt.
No problem.
Hot in there.
The last thing I'm going to say about fetal monitoring is there's a section in this article I put on Moodle about the categories. So you've answered all the questions about the fetal heart rate, and then you're going to say what category it is, 1, 2, or 3. I explained this thoroughly on the recorded lecture that's embedded in Moodle. It's here on this article. It is not on the exam.
Is it a documentation point, like
Yes.
the CMC?
Yep.
where you write-
Yep. Okay. All right, so I want to go over some things for the next hour that you might want to really pay attention to. So one of the things I'd like to say is we get a lot of women who come into the hospital thinking they're in labor. And the biggest, number one, determinant of whether they're in labor is not whether they're contracting or how painful it is, which they will be contracting and it will be painful, is we want to know, is their cervix changing? Okay? If their cervix is not changing, they are not in labor. Okay? So most of the time we will send those girls home. Some of them show up, especially if it's their first pregnancy, and they don't really know that the contraction pain that they're rating at 10 right now really is only a 2. And it's going to get worse when she really is in labor. But she might come in several times, guys, and she might feel stupid every time. And she might be very upset and disappointed, and she might beg you, please, let me stay, let me stay. But you can't let her stay. She's not in labor. But you've got to let her know it's okay. Okay? Because you don't want her feeling like you're thinking, oh, please, for Pete's sake, stop coming in, because she will stay home, she will be in real labor, and might have a problem at home, and it's because you made her feel like she was stupid. So we never make our patients feel like they're stupid, but in this case in particular, they really feel like they have no idea what to expect. So your discharge education with them is, if you have regular, consistent, painful contractions, come in, let us check you. Okay? She could have regular, consistent, painful contractions for a month and not be in labor. Braxton Hicks can be a really painful contraction. Okay? So you just got to reassure her, and maybe tell her to drink a big glass of water. What did I say about what IV fluids does? It hydrates the uterus and relaxes it, so maybe that'll help. Okay? Take a warm bath. Maybe that'll help. Okay?
If she just walks in, but she's been at a 2 for a week, or 4 even, because sometimes people are just walking around.
Uh-huh.
So do you look at her previous charting to be like, oh yeah, I think you're about a 5 now, or
Well, yeah, you can look at previous charting. A lot of times we just ask her, before we tell her what she's dilated to, what were you on your last exam and when was your last exam? Because sometimes her last exam was just 2 nights ago when she was here, and sometimes it was last week when she was at the doctor's office. Okay? So if the first exam was 2 centimeters and she comes in and she's now 3, I'm still not going to automatically admit her. So usually what we do is, so we got to see cervical change. Well, how do you see that? Well, you check them, you put them on the monitor, you check them, you check the baby, you make sure everything looks good there, and if it does, then you get her up and walk her for an hour. And then you bring her back, you put her on the monitor, you recheck her. And that's where we see if there's no cervical change. Okay? You know, if they were 2 last week and they come in and they're 4, they're having contractions every 2 minutes. You know, we may keep them around just to make sure. But a lot of these women, like the doctor, you'll call the doctor, of course. You don't just see them and send them home. You call the doctor and you say, this is the deal, blah, 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 blah. He says, you know what, I was going to induce her tomorrow morning. Just let her stay. I'll come in tonight and break her water. Okay? So even if she's not in labor, you still may keep her. But officially, true labor is cervical change. So, okay, so you're laboring this patient. She's progressing. Everything's going great. And she tells you, oh, you know what? I really feel like I have to have bowel movement. Can I get up to the bathroom? What are you going to let her do?
No,
You're not going to let her get up to the bathroom. What are you going to do then?
check her
Why are you going to check her?
to see if she's dilated to 10 and she can push.
Right. So when women start all of a sudden complaining of rectal pressure, they probably do not have to have a bowel movement. They probably have to have a baby. Okay? Let's see, what else do I want to tell you? Do you guys remember the stages of labor? What's the first stage of labor? Let's count backwards. There's 4 stages of labor. What's the 4th stage of labor?
Placenta delivery?
So they've delivered the placenta and it's a couple of hours of recovery afterwards. Stabilization. Okay? What's the 3rd stage?
Delivery of the placenta.
Okay, it's from the time that they've delivered the baby already, and it's the time that it takes to deliver the placenta. Okay? What's the 2nd stage of labor?
Delivery of the baby.
Delivery of the baby. It's the time she gets, starts pushing until the time she delivers the baby. So the 1st stage of labor is labor. Okay? But there's different phases in the labor, because that labor could take, 5 or 6 days. No, I'm teasing. That labor could take a long time. So it's divided into stages, 3 stages in particular. The 1st stage is the latent stage. So that's when she's, 1 to 4 centimeters. She's contracting. They're uncomfortable, but she's managing. Okay. The 2nd phase in the 1st stage of labor is the active phase. Okay. This is when she's really starting to make a lot of cervical change. She's contracting very frequently, every couple of minutes, every 2 to 3 minutes. They're very uncomfortable. She may be getting pain medicine at this time. Okay. And this lasts to about 7 to 8 centimeters when she, I don't know what that ringing is. Oh, when she is transition phase, okay? And this is where she's 8 to 10 centimeters. You can look at a woman most of the time and see that they're in transition, because one of the things they're probably doing is shaking and hyperventilating and getting all anxious, okay? That kind of happens to gals. Even with an epidural, you can see a lot of transition signs. So if your woman is, you've been taking care of her and she's, she's been, breathing through her contractions, she's been doing really well, and then you walk in the room and she's, doing all this stuff, you better check her. She might be ready, okay? All right, the philosophy behind pain medication during labor is not just so that the pain is decreased. Yeah, like that's what the woman says is why you're giving me pain medicine, is to make this pain feel better. But one of the reasons why providers like to give pain medicine during labor is because it makes the woman relax. So when the woman's relaxed, those strong contractions have nothing impeding them from getting down to the cervix and dilating it. If you have a woman who wants natural childbirth, she really needs coaching to keep her as relaxed as possible, because if she's doing this the whole time during a contraction, one thing she's doing is she's not taking in oxygen, which is depleting the uterus from oxygen, which is almost like a hypoxic event, which causes pain. Okay? So if you can keep her breathing, okay, she's going to get a lot of oxygen to the uterus. The other thing is when she's tensing up, she's almost building a wall between her contractions and her cervix. Okay? So a lot of times we have this woman who's just been laboring for hours. She's making very little progress. Okay? And she's like on the fence about whether or not to give pain medicine. I'm going to push her over the fence and I'm going to say, listen, you've been laboring a long time. You're getting tired. I need you strong when you push. And if I could just get you relaxed, I think I could get your cervix to dilate faster. Okay? And then she's like, give it to me. Okay?
Well, what's the first line that they're given now?
Well, most women go straight for the epidural. Most of the time. The women that were wanting to do this all natural, no medication, they might try IV, and we give fentanyl.
No more Stadol.
Well, some facilities use Stadol, some facilities use Nubane. Demerol and Phenergan are going out of favor, but we use fentanyl at CMC and St. Pat's.
Because it's got a shorter half-life, or what's the reason?
Why we use it?
Yeah.
Well, yeah, it does have a shorter half-life, but it's more effective and causes less, I mean, it does cause problems with baby, but less so than morphine or Demerol, okay? The one thing I will tell you, if your woman is going to IV medication, is you will not be giving it, no, I can't say that. You will use it cautiously if she's greater than 8 centimeters. The reason is if you give IV pain medicine, it does cross the placenta, okay? And so baby will be narcolized. And then if she's at 8 centimeters, she might deliver before baby gets rid of that narc, and baby will come out and not want to breathe very well. I mean, baby will breathe, but not great, okay? So you will use it cautiously after 8 centimeters. But if that's what she wants, she doesn't want an epidural, you can't force her to get an epidural, and your physician says it's okay, you'll give it. And you'll tell the people who are catching the baby, you know, she just had narcotics an hour ago or whatever, so they can be prepared.
Do you guys
Okay?
get a lot of verbal orders?
Yes.
There's not just like a standing orders list for...
Some physicians, so when there's a labor order set, and the physicians will go click all those orders, and then you can do whatever you want with their patient all day long. That really keeps the doctor out of the loop about what's going on. Some doctors want to know, so they're going to make you call. So they just want to know the status of their patient, so they're going to make you call and get the order for the pain medicine.
How many different OB doctors are there in town?
There's Dr. Brock, Dr. Knudsen, Dr. Berg, Dr. Harvey, Dr. Wyman. Partnership, I think 2 or 3 doctors there do OB patients. Dr. Fawcett, he's a perinatologist. He's absolutely wonderful. I hope you people can meet him. And then there's Dr. Mayo, Dr. Gibler, and Dr. Garnis, so that's 12. Plus, there's Jeannie Hebel, who's a certified nurse midwife.
Wendy, how many questions on the test?
There's 40 questions. You have 2 hours to take the exam. I know.
Better than our last test we took.
I'm just scanning through topics, okay? That's all I'm doing here. And I'm just trying to find good topics that I think need reinforcement. Okay? So just hold steady. Okay. All right. So one thing that we do when we have laboring patients and stuff, we either break their water or their water is broke. Okay. Why is that a big deal? Well, one, when their water breaks, whether we do it or they do it, we hope to have them on the fetal monitor because we want to make sure the baby tolerates that. And the one thing we can see if baby doesn't tolerate that is either a variable decel or a prolonged decel that actually turns to bradycardia. Because what happens is, as the water is rushing out of the uterus, so is the umbilical cord. And if the umbilical cord comes out and all that water comes out and then the baby settles down because there's nothing holding that baby up in there, floating, okay? The head settles down on the cord and the cord gets compressed and we see the variables decel, right? Because that's what happens when a cord is compressed. But the compression doesn't stop. So then we get the prolonged decel that proceeds into a bradycardia. So it's very important that you watch this woman when her water breaks, because if that cord does come out, then you need to do a vaginal exam. You need to put your fingers on the head and you need to push it back in the uterus and get it off the cord. You cannot put the cord back in. So you push that head up. Do you take your hand out? You leave it in there and you calmly tell the husband, would you mind hitting the code button? And people are going to rush in and you're going to climb up into the bed and you're going to ride on that bed to OR and they're going to do a C-section and you will not remove your hand until the physician pulls the baby out.
Do you have to do that, Wendy?
Huh?
Do you have to do that?
Let me tell you my story about that, okay? Because we did not go to the OR. This woman was 2 centimeters. She was in early labor. The physician came in and broke her water and walked out. And my baby's heart rate dropped. And as I'm gloving up, I yell for the physician, get back in here. I did the exam. I had the cord. I pushed the head up. I could not push the head up. I could not get the pressure off the cord. The physician then replaced me and could not get the pressure off the cord and told me to go get a scalpel. We did not go to the OR. She did not have an epidural. She did not even have IV fentanyl.
Oh my God.
And we cut her on that bed. The baby had heart rates in the 40s for 7 minutes.
Lester.
Baby did fine.
That's awesome.
Wow.
And this patient, her mother, well, okay, so they got there, we admitted her in labor, the husband said, I gotta go take care of the dogs and I'll be back. You have time, she's 2 centimeters, go do what you do. Her mother was with her when this happened and was in the room and the husband was gone. And her mother owned one of the nicest steakhouses in town. And me and the physician got a free dinner. Okay, the other thing I want to tell you is when you break the water breaks, you want to look at the color and you want to notice the odor. If the color is green, we have a problem. If it's bloody, we don't necessarily have a problem because laboring women bleed, but we want to make sure it's not too much blood. But if it's green, we have a problem. What that means is that's called meconium stained fluid. It means baby had a bowel movement in utero, which means baby is under stress. So, we will let her labor as long as the fetal heart rate on the monitor says we can continue with a labor. But we will have several people at the delivery who have the ability to intubate. So, currently, NRP, neonatal resuscitation, says that if you have meconium stained fluid, when your baby is born, if your baby is not screaming and vigorous, you immediately take your baby to the warmer, you intubate to visualize the cords, and then you stick a suction catheter in and suck around the cords. The deal is that if baby has swallowed or aspirated or has got some meconium in there, we need to suck it out because if baby breathed it in, baby could have a meconium aspiration pneumonia. Okay? Now, if your baby is delivered and immediately screams and cries and flailing all around, if there was meconium in there, your baby already aspirated it. There's nothing you can do. But if you've got a screaming, vigorous baby, you probably don't have meconium on the cords. The baby probably did not aspirate, and you're good to go. So those people came for no reason. Not for no reason, but that's what they're supposed to do. They came, the baby's screaming and crying. Okay, let's all move on, okay? But if your baby is limp and not crying, you take it immediately to the warmer and intubate to visualize cords. Now I'm saying that's the current recommendation for NRP. I heard rumor that may change and they may not do anything. They may not do any intubation at all. So I don't know. But that's where you guys need to be a member of your national organization. So if you're an orthopedic nurse, a diabetic nurse, a med-surg nurse, an ICU nurse, find your national organization and become a member. Because what happens is, I've told all you guys this before, didn't I? What happens is you will be a member of that organization, and any new standards of practice or evidence-based that comes along related to your specialty, you will get that notification, either in the journals they send you on a regular basis or email updates, newsletters and stuff like that, okay? And then you can go to your boss and you can say, hey, yo, and then she'll think you're like super smart, which you are, but okie dokie. All right. Anybody have any specific questions?
How long did it take that guy to get the baby out with just a scalpel? And that?
It took 2 or 3 minutes.
Just one.
They have to cut through the skin, and then they have to cut through the, they have to pull the muscles apart, then they have to cut through the uterus, and then they have to pull the baby out. So we had someone trying, continuing to try to get the baby's head off the cord. We had other people, doing things, grabbing this, grabbing that. We had one person standing with a mother who was horrified. We had 2 other nurses laying on this woman's chest.
To keep her from moving.
Oh my God.
I think
Like dramatic.
Huh?
Yeah.
She was screaming.
Right. Does she have another child?
Yes,
Oh, okay.
yes, she has had another child, but she opted to go for the repeat C-section.
Right. Schedule this one.
Sounds like just sobbing. Was the dog shaking? Did he have an adrenaline dump going, you think?
Yeah, we were both shaken.
Yeah.
We went out to the nurse's station, and I was sitting there trying to chart, and we hugged and started crying.
Was this in Wyoming?
Yes. I'm just looking through topics, trying to see something that I feel like was confusing. So just bear with me here.
Mary.
Can you go over epidurals
Yes.
and spinals and analgesias and anesthesias?
Okay. So your laboring patient is wanting an epidural. Okay. You need to have consent for the epidural. Do you get the consent?
No.
The
Thank
doctor
you.
does.
And so you've got consent, and now you're preparing the patient for the epidural placement, which happens right in the labor room. Most physicians have, or most anesthesiologists have the patient sitting on the bed, okay? And then you have them spread their legs, put their feet on a stool, and then they just try to round over that belly, okay? What that does is it takes the vertebra and it helps them open, okay? So so for an epidural, you get the patient in position and you give her an IV fluid bolus, okay? There's two main side effects from epidural administration, or spinal for that matter, or intrathecal for that matter. Itching, which they're more than happy to have itching over pain, and maternal hypotension. And if you have a maternal hypotension, you will have a fetal bradycardia. Okay? So we do a real quick fluid bolus, 500 to 1,000 cc's, right before he places the epidural. Okay? It doesn't matter that she's been in labor for 12 hours and has had 3 bags of fluid. He wants a bolus right before you place the epidural. Okay? So the epidural is placed. They use a needle just like an IV catheter. They have a flexible, soft catheter that feeds in over the needle. They pull the needle out, and then they tape the catheter in place. And then they hook it up to a continuous infusion. And then most anesthesiologists will also set it up with a PCA feature, where the patient can give themselves a bolus at every 10 minutes or 20 minutes or however they set it.
So during C-section, what do they, it's not.
In a C-section, they will do what's called a spinal, so it's just a different place that they hit. They inject the medicine, they pull the needle out, they're done. Okay? With your spinal anesthesias of any type, they are numb, usually completely numb. A lot of times with epidurals, they can move their legs, but they're really heavy. And then after delivery and after the episiotomy is repaired, you turn the epidural off and you pull the catheter out. And then you do the recovery. Now, one thing we want women to do after the epidural is pulled, or after delivery, is we want them to void very soon, because a full bladder will keep a uterus from contracting and therefore increase her bleeding potential. So we want to get them up and void them, have them void as soon as possible. But if they've had a really dense epidural, that could present a problem. So if your woman hasn't voided within 2 hours after delivery, you will assess her bladder, you will palpate her bladder, and you will palpate her fundus. If her bladder is extremely full, of course, you'll feel it on bladder palpation, but you'll also feel it because the uterus will now be displaced. Okay? So it will be either to the right or the left of the umbilicus. Okay? You need to get her to void, but if you can't get her up and walk her, what do? You do a catheter. Now, some people say, well, try the bedpan. Well, if she can't walk because she's numb, she's not going to feel the urge to void. So I go straight for a straight cath. If my assessment shows that she has a full bladder, her uterus is displaced, and her bleeding's heavy. If it's not, I'll give her 1 more hour to try to get her legs to come back. Okay? And then so we want to just make sure that even 6 hours after delivery, she's still able to void, okay? There's no neurological damage done. It's just, it's still numb from the epidural, okay? Or spinal, whatever she has. And so most C-sections will get a spinal. And the mom can be awake, and dad can be in there, and baby is born, and we go to the warmer, and we dry baby off and make sure baby's doing well. And then we take mom and put baby skin to skin in the OR, okay? But if she does have general anesthesia where we put her to sleep, and we reserve those for extreme emergency situations, then she has all the normal risks of someone who's had anesthesia, okay? No more, no less. But baby also has the same risks, okay? So your baby nurse will want to, watch this baby very closely. And when she gets out of anesthesia and starts waking up, she's going to have a pain crisis because there's no pain medicine in general anesthesia. So you're going to be a couple hours getting that under control. Okay.
And so what medications are used for your epidurals? Is it just straight opioid? Or
Yeah, they use fentanyl. They have premixed bags of fentanyl with some bupivacaine, some numbing. Okay. Okay. Remember that after delivery of baby, you really want to dry your baby. You can put baby straight to mom's chest after delivery, right after delivery, just right up there. You really want to dry this baby. Why do you want to dry the baby? Okay, temperature is a big issue for babies. You can do all your assessments and baby cares on the chest. You can give IM injections. You can even measure the head and chest. You can do your head-to-toe assessment. You can, put the erythromycin ointment in the baby's eyes, which is every baby gets erythromycin ointment to protect their eyes from infection. You can do a lot of stuff on mom's chest. Okay.
Do you have moms who don't want that to happen?
Not too many.
This is, the chest thing is kind of new.
Yeah, it's called skin to skin, and for the first 24 hours, lactation people would love to see this baby skin to skin the entire time. It promotes breastfeeding, and just that skin to skin contact between mom and babe. The studies show that those moms and babes breastfeed better, have an increased breast milk supply than opposed to those who don't. Plus, it helps baby with transition to be skin to skin. It helps keep baby warm to be skin to skin. And the studies have shown that babies that are skin to skin, their heart rate drops, normalizes, their respiratory rate normalizes. Okay, so a lot of times, like preterm babies, depending on how preterm they are, touch can be very debilitating to some preterm babies. It could actually be contraindicated depending on how preterm they are. But later preterm babies, they're finding that skin to skin is helping these babies transition a lot quicker, requiring less oxygen supply. So yeah, it's really something that's starting to take off.
They had the smallest baby born at Community
Yeah.
while I worked there, and her dad would come in for an hour every day, and I mean, she was under a pound, she was tiny, and they let him do skin to skin with her for an hour a day.
Right.
And it was the cutest thing.
Yeah. So when your babies are born, one thing that hopefully you read in your book is apnea in babies. Does anybody have any questions about apnea? How long do you have to give a baby to diagnose them with apnea?
20 seconds.
20 seconds. Okay. So babies have irregular breathing patterns. They'll breathe, and they'll stop breathing for several seconds. And that's normal, and that's okay. When it's not okay is when it's greater than 20 seconds.
So as the breathing pattern is irregular, does that affect their heart pattern as being irregular as well?
No, because babies have an irregular heart rate. So any movement on the baby you can be listening to your baby's heart rate, okay? And if that baby is lying super still, you know, the baseline rate is pretty consistent, okay? But if that baby is moving at all, you can actually hear an increase in the heart rate. If that baby is crying, you know, their heart rate could be 170, okay? And as you're listening and that baby's calming down, you can hear that heart rate drop. So fluctuations in the baby's heart rate, just like on the tracing, you know, there could be fluctuations every few seconds, you know, and you can hear those fluctuations. Bilirubin. Does anybody have any questions about bilirubin and jaundice? So there's two different kinds of bilirubin, correct? One's unconjugated, one's conjugated, direct and indirect. And of course, if you add both those bilirubins together, you get the total bilirubin, right? The unconjugated is the breakdown of red blood cells. Babies have breakdown of red blood cells, so do we. But, you know, the delivery might set baby up for an increase in blood volume, blood cells to be broken down. So we could see jaundice because it's a process of taking that unconjugated bilirubin, binding it, getting it to the liver processing it, putting it in the gut, and then some is eliminated, some is reabsorbed back into the liver. So if you've got a large breakdown of blood cells and you've got this reabsorption of bilirubin, you could have an increased bilirubin level in your baby. You can see an increased bilirubin level in a baby because what? They're
Yellow.
They're yellow. Okay. What do we like to do to keep babies out from under the primary source of hyperbilirubinemia, which is
Feed 'em.
lights? What?
Feed 'em.
We want to feed them. Okay. We want to help them flush this stuff from their system. Okay. All right. If they have an elevated bilirubin level and mom's trying to feed them, what problem could she encounter with a baby who has a high bilirubin? Sleepy. So then baby doesn't want to eat. So then the bilirubin does what? Goes up, and then the baby gets sleepy and doesn't want to eat. So it's a vicious cycle. if your baby had a traumatic delivery and your baby was really big, what complication do you think you would see on the baby?
Hypoglycemia.
Hypoglycemia, why? Why they're big, they're fat, they should have a lot of blood sugar.
It's going to take more energy for them. They're going to be burning it up. They have a larger surface area that they have to keep warm.
Right. One of the biggest things, whether you just have a large baby or whether you have a diabetic mom, is when the baby's in utero, the baby gets all mom's blood sugar, and the baby produces insulin to handle all that blood sugar. So all this insulin, baby's pumping out, and then you cut off the sugar because you clamped the cord. The baby's got all this blood sugar. I mean, all this insulin. Okay, so it will eat up what baby has. Well, to store it, not eat it up. You know what insulin does. And then baby's blood sugars will drop. Okay. The other thing that you will see on these big babies that you want to watch for with big babies or traumatic deliveries is their arm movement. Are they moving both arms? Why do we care if they're moving both arms? Shouldn't they be moving both arms?
Trauma.
They could have a clavicle fracture, so they'll just be moving this arm. All right? So. So there's a lot of things that go on with women postpartum. They have a lot of emotions, a lot of things going on. They go through different transition periods of being a mother and stuff like this. But one of the things, especially, with anybody, a newly diagnosed diabetic, a newly diagnosed congestive heart failure patient, you come in here, okay, and you tell them all this stuff about their condition, okay? Where is that information going? Right down here. Okay, so just know that 5 minutes ago when you told the mother how to latch the baby on and how to hold her baby, that you go in there finding her doing something else, okay, because she had no idea what you just said, right? She can't comprehend all this information. And we've got so much to teach postpartum families that we teach it all day long, every time you walk in the room, okay? And when I do my teaching, especially if I'm with this patient for a prolonged period of time, I might do my initial teaching, but then the next time I go in the room, I ask her what's right and what's wrong. I ask her, what are you looking for when you're looking at your baby for latch? Because I don't want to just keep telling her information. I need to know that she knows the information. Telling her tells me nothing, okay? So go in your room and, don't be like, hey, what are you supposed to be seeing? Just like, hey, so how's your baby's latch? And she says it's good. And then I say, okay, well, what makes it good? What are you looking for? Okay? And so whatever you're teaching, just go in and start quizzing them now in a very non-aggressive way to assess their learning. And then when you're ready to send them out the door and they are saying to you, I don't know what I'm doing, I don't want to go home. And you say, yes, you do know. Remember, we talked about it. You told me everything. You know exactly what you're supposed to do. Okay? Reassure her, or them, or whoever.
Give them a test.
Yeah. There'll be a test, and if you fail, we're taking your baby.
Test. Now we're going to go over it.
Wonder if you walked in the room and you've got this mother and her baby's in the crib crying and the mother's sitting in the bed. You walked in the room because you heard the baby crying down the hallway and you've been hearing it for about an hour. And you walk in the room and the mom's sitting on the bed and the baby's in the crib over there crying. What is your first thought? My first thought is, what the hell are you doing? Okay, but that's not what you're supposed to be thinking. Okay? What do you think's going on with this mom? She doesn't know what the frick to do, or she is at her wit's end because she is so scared and she doesn't know what to do with this baby. So I don't know. Is she a bad mom? Do you need to call CPS?
So you say, oh, can I pick up your baby for a moment?
Yeah,
Do you ask
yeah.
permission?
Yeah. And then the other thing is when you're helping women with breastfeeding, okay, and it's not going well, and the baby's screaming, and she doesn't want my milk, she doesn't like my milk, okay, and the baby's screaming. You know what I do? I just say, can I just hold your baby for a minute, okay? And I take that baby from that mom. You gotta have a calm baby to breastfeed, okay? And they don't know how to calm their baby. They don't know what to do. All they know is they're trying to feed their baby, and their baby's acting like she's the plague, okay? So help calm the baby. Show her how to calm the baby. Tell her this is normal. She doesn't know what she's doing. The baby doesn't know what she's doing. Breastfeeding is a natural thing, but no one knows how to do it, okay? So people have to learn, even the baby, okay? All right. So don't be afraid to take their baby. You know what I'm saying? Don't be afraid to say, here, let me just calm the baby down for a minute and we'll talk. Or, something like that, okay?
Can postpartum depression happen
That quick? Usually not. It's usually not the postpartum depression that's the problem when they're in the hospital. It is the hormones that are making them like crazy wackadoodle, but it's not so much the depression as it is the uncertainty, the fear, right, the feelings of being inept. Like you go in there and you calm that baby down, yeah, that's helping her out, but that's also telling her, you don't know how to take care of your baby, I do. Okay, so it's a real thin fence you're standing on, okay? But you need to do it, okay? And you need to just tell her, like, you've never taken care of a baby, and we're going to show you how, and we're going to make sure that you're, and then you have all these resources and stuff, so they're not alone, okay? They're not alone.
What do you do if you've got a psych patient that just delivered a baby and their baseline is nuts?
Okay, so like if you do have a safety issue, if there is a safety issue for baby, you will confiscate that baby, okay? But like CPS is involved, the doctor is involved, like it's not going to be like all the, you're not going to see this in the hospital all of a sudden, this normal person going wackadoodle, okay? But if they do have a history, someone can have a psych history and be a very good mother, but you're going to be looking for the cues and the red flags, okay? There are babies that have been delivered and given to mother, and before discharge, we have taken those babies. So you need to be aware of the cues, okay? You need to be able to differentiate a mother who feels like she doesn't know what she's doing to a mother who doesn't want to, is not going to participate, okay? All right, what are some more topics I can see from my list of topics here?
Show us and we'll tell you.
Whatever's on the test.
With our card.
Okay, so when we're doing our fundal checks on our patients, remember our bubble P mnemonic? Okay, so we're doing our focused postpartum assessment now. And we get to the fundus. Where should the fundus be?
midline?
Midline. And where?
At the umbilicus.
At the umbilicus.
Below.
Or below. What if it's above? Like, there's some that are above. What's that mean?
You're probably going to feel it and make sure it's not body.
Right? She might need to pee. What else might be going on if she has a fundus above?
Hemorrhage.
She could be bleeding into her uterus that you're not seeing on pads. Watch for postpartum hemorrhage. So you assess this woman. Her fundus is above the umbilicus. You massage the fundus, it's firm. You do not get any clots or blood on your massage. Her vital signs are stable. Her saturations are stable. Her bladder is empty. What do you do now? What's going on now? The fundus is above you. Everything's normal. I'll recheck her in a couple hours. Okay? There's not always a problem because things are out of the normal, but if they're out of the normal, you need to assess everything, okay? And decide what condition she's in. Do you guys remember what, I didn't get to show you a picture of this and I wanted to. I even went all over, I mean, besides the picture that's in the textbook, you know, of a drawn rectus diastasis. You know what, remember what that is? The dominus muscle that's separated, it looks really freaky. I tried to find pictures on, I even went on Google images and tried to look for pictures, and none of them were appropriate. But that's not a problem. You might feel that when you go in to assess, or you might feel that even in labor. It just feels really freaky. Okay, but it's okay. Let me see if I can think of one more thing to tell you.
Wendy, what does the rest of bubble E stand for again?
Okay, bubble is breast. U is uterus. B-U-B. Bleeding. Bowel, bladder. L, no, wait a minute, no, not bleeding. Huh? Bladder, bowel. Lochia, E. Episiotomy, thank you. H is hemorrhoids or homins, which we don't really look at homins. And then E is edema. Huh? Oh, emotions, sorry. Yes.
Thank you.
You're right. So, I guess that's it. Anything else? Any questions? Okay, so like this was a freaky thing, being able to have an in-class review. There will be no more in-class reviews, just because I didn't have time. I don't have the time. All right, guys. I'll be anxiously waiting for the to look. 5.
By the way, the thing that you did on the strips, did you finish it?
What's that?
It was really good.
Oh, good,
They're
good.
recording. Except for when your dog barked. I literally, I'm not sure. It's like sitting all quiet in the basement.
Well, my husband walked in and she thinks she's a guard dog and she's only 10 pounds.
Well, she was like following us. It not worked out that way. And it felt, I was like, I need to change my direction.
So if this board does have whenever they bring the water, first thing that you're going to do is
Did I look up that?
and then
And it's not like
if you decide, then you'll know that.
Right, so when I said you'll see a variable deceleration, you'll see the drop, but it won't come back up. It's just going to continue. The pressure is going to continue. There will be a sudden drop.
I printed them already, waiting. Just for you.
Yeah, she doesn't want one.
You got it. I printed them last night.
You know, I want it's a pretty word. It is just great. I don't know what's like it's just
What time is it?
flush knee, so, knee temple, and knee is a rupture, and the wheel side.
So then you just did labor, from the labor.
Yeah, and then we passed out like
Oh my God.
Bang it to you for paperwork.
Yeah,